Is it visible now?
Yes, sir.
Okay. So you can this chart gives a more number of drugs than what the question is asking. So among the benzodiazepine groups nowadays we prefer to use midazolam, and the name of the drug as well as the brand name is given here. And some people use lorazepam also. Some people use diazepam, which is a very time-tested old drug. But the usage of these two drugs have become now very rare because of the availability of midazolam and the short nature of action. It becomes more easier to titrate the dose. So the mechanism of action, typical adult dose, pharmacokinetic properties, adverse side effects. So here if you take midazolam, it is a GABA A agonist. So if you write GABA A agonist in the exam, that is more than enough. You need not go on to explain that it opens the chloride channel and causes hyperpolarization. All that is not necessary. This itself will fetch you marks. And it can give a bolus of 1 to 5 milligram and then continue it as a, in ICU sedation, we always first start with the bolus and then go on to give an infusion to maintain the patient's sedation.
No, I know.
The, the main thing is to try to clean off the sedation as much as possible so that we don't over sedate the patient. Similarly, if you are using neuromuscular blockade for patients who are on ventilator, we try to reduce the dose or the infusion of NMB, neuromuscular blocking drugs also, so that the idea of treating any ICU patient is to take them off the ventilator and make them breathe on their own and get back their normal consciousness and sensorium as early as possible, so that they will feel more natural and more normal, so that the recovery will be much more faster. So that is the main idea in treating any ICU patient who requires mechanical ventilation. So the sedation is required mainly for patients who are on mechanical ventilation or patients who have some cognitive dysfunction with delirium. They only require sedation. Otherwise, normally we don't resort to sedation in every patient. So these are the things that you have to keep in mind, and the side effects. So the high risk of delirium and tolerance is there if the patient has got any pain. For example, a polytrauma patient who is on ventilator, if he is on pain, giving midazolam alone will make him worse because it doesn't give any pain relief. So we have to find out what exactly the nature and condition of the patient. So if it is a painless COPD patient on ventilator, he will not have much pain because of any stimulus. He needs only to tolerate the endotracheal tube and cooperate with the mechanical ventilation. So there, midazolam will be useful. On the contrary, if a post-operative patient who is on ventilator, he may not remain quiet with midazolam alone. So there is a risk of delirium and cross sensitivity. So you may require more drugs, and all these problems are there. So the pharmacokinetic properties are its half-life is 3 to 11 hours. The active metabolite accumulates with prolonged infusion, and it is metabolized by hepatic oxidation and excreted by renal route. So you have to be careful when the patient has got a hepatic or renal impairment. Then coming to the next drug, propofol. This is also a GABA A agonist, and other effects including glutamate and cannabinoid receptors also. It has got some effects, and it can be started at the dose of 50 to 200 milligram per hour or 1 to 2 milligram per kg per hour. This is the adult dose. And of course, the pharmacokinetics or half-life is to this infusion. Longer infusion produce because of redistribution of fat stores, and it is metabolized by hepatic glucuronidation and hydroxylation. And the unwanted side effects are it is a vasodilatory property, causes negative inotropy, and faster infusions are definitely associated with hypotension and bradycardia. And this propofol infusion syndrome, which causes, I think you have to describe these features of the propofol infusion syndrome, which is more common in pediatric patients. When you use the drug as an infusion for more than 24 hours, it produces lactic acidosis, arrhythmia, and cardiac arrest. And so it is mostly associated if it is used for more than 36 hours or above 24 hours, and at the rate of 4 to 5 milligram per kg per hour, and it can lead to hypertriglyceridemia and pancreatitis also. So it is better to stop it in less than 24 hours. And the pain on injection here is not a great thing, because the ICU patients are the initial first injection only is going to be painful if you give a bolus, but once infusion is started, that is not going to cause much of a pain. And the third drug, of course, we use is Dexmed, and it is an alpha 2 agonist. And this is the loading dose of 1 microgram per kg per hour. It's not required in ICU patients because that will cause a sudden hypotension and bradycardia. So you can always start straight away with the infusion dose to the patients who are on mechanical ventilation. And it's a short half-life of 2 hours, and there is no accumulation. So all the drugs you must mention whether they have a cumulative property or not. Whenever you mention these drugs, please read and find out whether they have cumulative property on prolonged infusion. And this context sensitivity half time, that is whenever you want to wake up the patient, you have to mention that property of when to stop the drug, so that you can wake up the patient and try to see his sensorium and his conscious level. And the side effects are transient hypertension initially, then hypotension, bradycardia, dry mouth, and nausea, which are mentioned. And these other two drugs are also used in conditions where there is associated with pain. Just giving propofol or midazolam will not be suitable. So you may have to combine it with remifentanil or fentanyl for pain relief. So, but because the question is only on 3 drugs, even if you choose remifentanil or fentanyl, there is no harm. You can mention the same properties, how they act. They are mu opioid receptor agonist, and the dosage of fentanyl for infusion is 20 to 100 microgram, and half-life is 1.5 to 6 hours, highly fat soluble, and accumulates with prolonged infusion. So you have to be careful, and metabolized by hepatic oxidation. But the metabolites are not active. So whenever you give a drug for infusion, you must make sure that the breakdown product or metabolites of the drug should not have. For example, ketamine, if you use as an infusion, the norketamine is also equally having 60% action. So you have to be very careful if you use such drugs whose metabolites also have the same action like the parent compound. So this sort of name, mechanism of action, adult dose, pharmacokinetic properties, adverse side effects. So if you make a tabular column on these 5 points and try to write it, you will get the same marks, and you can complete the answer in a much more shorter time, which will help you to go ahead with the other questions easily. Okay. Right.